Welcome to the Deep Dive Ortho. Today, we're taking a closer look at a condition often, well, misunderstood. It's frequently encountered in practice, yet sometimes more complex than its popular name suggests. Medial epicondylitis. You probably know it as golfer's elbow. But we're going to unpack its true nature, its impact on a really quite diverse patient group, and the most effective strategies for diagnosis and management. We'll explore why its pathology kind of challenges its very name and how we as medical professionals can best serve those affected.
Precisely. It's a condition that it really demands a nuanced understanding. We need to move beyond those simplistic labels to truly grasp its degenerative underpinnings and the whole spectrum of patient presentations. We'll delve into the anatomical specifics, the subtle clinical cues, and the evidence guiding our treatment decisions.
Okay, let's unpack this then. Our mission for this deep dive is to provide you with a comprehensive, evidence-informed perspective on medial epicondylitis, equipping you with the latest insights to, hopefully, enhance patient care and outcomes. Let's start right there, clarifying what medial epicondylitis truly is. The term epicondylitis immediately suggests inflammation, doesn't it? But our understanding has evolved quite significantly. So what's the more accurate picture for us to consider now, and which specific anatomical structures are primarily involved?
That's a really crucial distinction. Yes. While early stages might involve some inflammation, medial epicondylitis is predominantly a chronic tendinosis, which means we're dealing with degenerative changes, often characterized by angiofibroblastic hyperplasia or simply tendinosis, rather than an acute inflammatory process.
Right, so less itis.
Exactly. Histological examination, for instance, it typically reveals things like hypertrophic immature fibroblasts, disorganized collagen, and vascular hyperplasia, but notably without the presence of inflammatory cells. Or very few, anyway. Regarding the anatomy, we're focusing on the medial common flexor tendon of the elbow. This is the shared origin of 5 key muscles: the pronator teres, flexor carpi radialis, palmaris longus, and flexor digitorum superficialis. They're all innervated by the median nerve, plus the flexor carpi ulnaris, which is supplied by the ulnar nerve.
Got it. 5 muscles converging there?
Yes, this conjoined tendon, it's approximately 3 centimeters long. It crosses the medial ulnohumeral joint and actually acts as a secondary stabilizer running parallel to the ulnar collateral ligament. And while historically the pronator teres and flexor carpi radialis were thought to be most affected, current literature suggests that actually all these muscles can be involved, with the possible exception of the palmaris longus.
So it's a degenerative process. That really changes how we approach it, doesn't it? Now, who are the typical patients presenting with this condition, and what activities or risk factors commonly contribute to its development? Is it truly just golfers, or is that name, as I suspected, a bit of a red herring?
It's certainly not limited to golfers, despite the common name. It's definitely a bit of a red herring. Medial epicondylitis arises primarily from repetitive strain, particularly activities involving frequent gripping under load, forearm pronation, and wrist flexion.
Okay.
While it is prominent in athletes including baseball pitchers, javelin throwers, bowlers, weightlifters, rock climbers, and yes, golfers and tennis players, especially during those high-energy valgus stress phases of a thrower's swing.
Right.
Over 90% of cases are actually not sports-related.
90%. Wow.
Yes. Many patients are from labor-intensive occupations. Think carpenters, plumbers, construction workers, utility workers, butchers, or maybe catering staff. Anywhere where repetitive, forceful activities or constant vibration are common.
That makes sense.
And beyond specific activities, several risk factors increase susceptibility. In athletes, these might include training errors, improper technique, perhaps equipment issues, or a lack of strength, endurance, or flexibility. For occupational cases, heavy physical work, excessive repetition, high body mass index, smoking, other comorbidities, and even high psychosocial work demands are significant contributors.
So quite a range.
Indeed. General risk factors include tobacco use and type 2 diabetes mellitus. And obesity seems particularly associated with increased risk in women.
That's really interesting. So what's its prevalence compared to, say, lateral epicondylitis? We tend to see more of that, don't we? And are there any demographic trends we should be aware of?
You're right. Medial epicondylitis is significantly less common than its lateral counterpart. It accounts for only about 10 to 20% of all epicondylitis cases. In fact, some studies indicate it's 7 to 10 times less frequent.
Quite a difference.
Population studies suggest a prevalence around 0.4%, with an incidence rate of 5.6 per 1,000 person years, observed in military populations, for example. It most commonly affects individuals between 45 and 64 years of age. Now, While one school of thought suggests it affects men and women equally, other studies indicate it's actually more prevalent in women.
Interesting.
3 out of 4 cases typically present in the patient's dominant arm. The good news, though, is that for most patients, it tends to be self-limiting. Approximately 80% recover within 1 to 3 years.
Okay, that's somewhat reassuring. Given these diverse causes, then, how does a typical patient present? What are the key historical elements and physical exam findings that really guide our diagnosis, the bread and butter signs?
Well, patients typically report an aching pain on the medial or ulnar side of the elbow. It often radiates down into the forearm and wrist. This pain is usually insidious in onset. It gets worse with forearm motion, gripping, or throwing, and tends to resolve with rest. However, it can also manifest acutely, perhaps following a traumatic blow or a sudden violent muscle contraction. It's common for patients to report morning exacerbation of pain, and chronic cases may involve reduced grip strength. Importantly, and this is something to always ask about, up to 20% of patients may also report associated numbness or tingling.
Ah, the ulnar nerve proximity.
Exactly. Most commonly in an ulnar nerve distribution, precisely because of that proximity. On physical examination, acute cases might show some swelling, erythema, or warmth, though these are typically absent in chronic presentations. The hallmark finding is tenderness located about 5 to 10 millimeters distal and anterior to the medial epicondyle, particularly over the conjoined tendon, the pronator teres, or the flexor carpi radialis.
And provocation tests.
Yes, pain is reliably elicited with resisted wrist flexion, and perhaps most sensitively with resisted forearm pronation. Just remember, when testing for pronator teres involvement, make sure the elbow is flexed at 90 degrees.
Good tip.
2 key provocative tests are the active and passive components of the golfer's elbow test. In the active phase, the patient resists wrist flexion with the arm in extension and supination. In the passive phase, the wrist is passively extended with the elbow in extension. A positive test elicits pain.
Okay.
And it's also crucial to assess for concomitant conditions, things like ulnar neuropathy, using Tinel's test along the cubital tunnel, and evaluate ulnar collateral ligament stability, especially in throwing athletes, using maneuvers like the milking maneuver or a valgus stress test. Oh, and a flexion contracture might be a late finding in untreated cases.
So it sounds like a robust clinical diagnosis is often sufficient. When then should we consider imaging? When do we need to sort of pull out the bigger guns? And what are the benefits of each modality?
You're right, the diagnosis is primarily clinical in many cases, no doubt. However, imaging becomes instrumental when the clinical presentation is a bit ambiguous, or we need to rule out other potential causes of medial elbow pain. It's about certainty and excluding other issues.
Breaks up.
Radiographs, plain x-rays, are usually normal, but they are invaluable for excluding other bony pathologies like fractures, especially in, say, pediatric populations where growth plates are vulnerable. They can also reveal periostitis or calcific tendinopathy in about 20 to 30% of patients. And stress radiographs can assess valgus instability.
Okay, so good for bone issues, meaning.
Then there's ultrasound. It's a highly useful, cost-effective, and dynamic tool. It boasts high sensitivity and specificity around 95% and 92% respectively for diagnosing medial epicondylitis. On ultrasound, we look for focal hypoechoic changes within the common flexor tendon, thickening of the tendon sheath, potential partial or full thickness tears, neovascularization on Doppler, and cortical irregularities at the medial epicondyle.
And the dynamic aspect.
Ah, yes. Its dynamic capability is also excellent for assessing ulnar nerve subluxation or collateral ligament instability. You can see things move in real time.
Very useful. And MRI.
Magnetic resonance imaging, MRI, is generally considered the gold standard, especially for soft tissue detail. While it can certainly confirm tendinosis, you might see a thickened common flexor tendon sheath, increased T2 signal intensity. Its primary value, I think, often lies in ruling out other, often coexisting pathologies.
Such as?
Things like ulnar collateral ligament strain or tears, osteochondritis dissecans, or other soft tissue injuries and loose bodies. It really gives you the full anatomical picture. And finally, if there is strong suspicion of ulnar nerve involvement.
Right, the tingling.
Exactly. Then electromyography, EMG, and nerve conduction studies, NCS, can provide further diagnostic clarity regarding nerve compression or neuropathy.
That provides a very clear diagnostic pathway. Thank you. Moving on to management then, what does the evidence tell us about the most effective treatment strategies, particularly given that, as you said, it's often more challenging to treat than lateral epicondylitis?
Yes. The cornerstone of management for medial epicondylitis is non-operative. And it's true, it can be more challenging to treat than lateral epicondylitis, and a prolonged trial of conservative care is generally warranted. We're talking months, often. We can think about non-operative treatment in 3 phases, as outlined by Sakati and colleagues. I find this framework quite helpful.
Okay, phase 1.
Phase 1 focuses on cessation, or perhaps more realistically, modification of offending activities, reducing their volume, frequency, or intensity. This needs to be combined with pain-relieving modalities. We have to acknowledge that for professional athletes or manual laborers, this can be incredibly challenging. Patient adherence is key here.
Absolutely.
Initial pain relief typically involves ice, particularly after activity, and non-opiate analgesics like paracetamol and NSAIDs, both oral and topical formulations. Importantly, opioids are not indicated. Topical nitroglycerin patches have also shown some short-term benefit for tendinopathies in some studies.
Interesting. Okay, phase 2.
Phase 2 centers around guided physiotherapy and rehabilitation. The primary goal here is to achieve full, painless motion at the wrist and elbow. Exercises should progressively incorporate eccentric activity, stretching, and isometric work, gradually building to resistive exercises aimed at surpassing pre-injury strength. This isn't a quick fix. It requires persistence.
Right, progressive loading.
Exactly.
Yeah.
Various adjunctive modalities may offer relief. Things like dry needling, possibly extracorporeal shockwave therapy, though recommendations are still evolving for medial specifically. Electrical stimulation, ionophoresis, phonophoresis, and ultrasonography. Soft tissue and manipulation techniques seem to facilitate more vigorous strengthening too. Bracing can also help, maybe a night splint or a counterforce brace positioned about 2 centimeters below the medial epicondyle to help unload the tendon and reduce pain. Kinesiology taping is another option some find useful.
And phase 3.
Phase 3 involves modifications to those previously offending activities, coupled with a maintenance exercise regimen. This is crucial to sustain flexibility and strength and reduce recurrence. It includes things like adjusting sporting equipment, maybe a larger racket grip, or looser strings for tennis players, and refining technique. It's about preventing it coming back.
That phased approach makes a lot of sense, building it up gradually. And what about complementary therapies, particularly injections? There's always a lot of discussion around their efficacy, and patients often ask about them.
Indeed, they do. Well, corticosteroid injections, often done ultrasound-guided, given the proximity of the ulnar and medial antebrachial cutaneous nerves. They can offer short-term symptom relief, typically up to about 6 weeks. However, studies have consistently shown no long-term benefits at 3 or 12 months post-injection compared to placebo or other treatments.
So a temporary fix at best.
Often, yes. And multiple injections should generally be avoided due to risks like skin depigmentation, subcutaneous atrophy, potential tendon weakening, and nerve injury. Other treatments like platelet-rich plasma, PRP, autologous blood, botulinum toxin, and prolotherapy have shown some promise in refractory cases, particularly, again, in lateral epicondylitis. But more research is really needed to fully assess their efficacy, specifically for medial epicondylitis. The evidence isn't quite as strong yet. Ultrasound-guided percutaneous tenotomy can also be attempted before considering surgery in those really stubborn cases.
Okay. And when do we finally consider surgical intervention? If all that fails, what does surgery typically entail, and what are the realistic expected outcomes?
Surgical management is usually a last resort. It's indicated only in refractory cases where, say, 6 to 12 months of compliant non-operative treatment has failed, and symptoms are severe and really impacting quality of life. It's a rare occurrence, though. One study suggested only about 2.8% of patients ultimately require surgical intervention.
Very small percentage, then.
Yes. An open surgical approach is generally preferred, mainly because of the proximity to the ulnar nerve and the ulnar collateral ligament. You need good visualization. The procedure typically involves debridement of the degenerated tendon tissue and release of the common flexor tendon at the medial epicondyle. Sometimes epicondyle cortical drilling might also be performed to try and enhance vascularity. And if there's concomitant ulnar neuropathy present,
A nerve issue again.
yes, then a cubital tunnel release or even transposition of the ulnar nerve may be performed at the same time. Post-operative care usually involves a brief period of immobilization in a sling, maybe 1 to 2 weeks, carefully avoiding volar flexion of the wrist. Early range of motion exercises commence after 2 weeks. Gentle isometric exercises introduced at 3 to 4 weeks, followed by a progressive strengthening program between 6 and 12 weeks. A gradual return to sport-specific activities usually begins between 3 and 6 months post-op. It's a steady progression.
And the outcomes.
While surgical outcomes are generally reported as good to excellent in about 80% of cases, it's worth noting that the prognosis can be less predictable compared to lateral epicondylitis surgery. Furthermore, and this is a key point for patient counseling, patients with preoperative ulnar nerve symptoms tend to have worse outcomes. The degree of ulnar neuropathy seems to directly correlate with less favorable clinical results after surgery.
It sounds like a long journey for some patients, especially if surgery is needed. What's the overall prognosis we can expect? And what potential complications should we be vigilant for, both in the condition itself and maybe from treatment?
Overall, the prognosis for medial epicondylitis is generally favorable. Most patients achieve significant relief and return to their prior activity levels through those conservative measures we discussed: physio, non-opiate pain relievers, bracing, activity modification. But as we've noted, its course can be more unpredictable compared to lateral epicondylitis. That figure of about 80% experiencing a self-limiting recovery within 1 to 3 years is probably the key takeaway.
Okay, and complications.
The most common complication is persistent pain or recurring symptoms, which really highlights the importance of that phase 3 maintenance. Associated conditions can include ulnar neuropathy, as we mentioned several times, ulnar collateral ligament injury, carpal tunnel syndrome, even lateral epicondylitis, and rotator cuff tendinitis. It often doesn't exist in a vacuum. For the rare cases requiring surgery, potential complications include medial antebrachial cutaneous nerve neuropathy, ulnar nerve injury, or infection. And even with technically successful surgery, about 20% of athletes may not fully regain their previous level of athletic performance. Managing expectations is vital.
That really underscores the importance of a well-rounded approach. How vital is the interprofessional team in managing these cases, which can clearly become quite complex? And what practical advice would you give regarding patient education and referrals?
The interprofessional team is absolutely pivotal, crucial. While primary care clinicians can certainly manage many straightforward cases, severe or refractory situations definitely warrant consultation. Perhaps with a physical medicine and rehabilitation specialist, a sports medicine physician, or an orthopedic surgeon. Early detection and treatment, coupled with activity adjustment and appropriate non-opioid pain management, are key for optimal outcomes, getting the right input early.
And the role of physio.
Physical therapy plays a dual role, not just treating the active condition, but also establishing preventative measures and maintenance programs to forestall symptom recurrence. It's a long-term partnership. Educating patients on early rehabilitation, the importance of modifying or avoiding aggravating activities, and setting appropriate expectations for recovery time is paramount. We should provide clear instruction on home stretches and a maintenance exercise regimen. Empowering them to manage it themselves helps prevent recurrence.
Giving them that control.
Exactly. And when referring a patient, providing comprehensive details is so important. Include the history of the present illness, physical examination findings, a detailed social history covering occupation, hobbies, sports, the treatment objectives, and any therapies already attempted. This ensures a holistic understanding for the next clinician. This collaborative sharing of information across the healthcare team truly enhances the delivery of comprehensive care and, ultimately, improves the patient's quality of life. Seamless care is the goal.
What a comprehensive deep dive into medial epicondylitis. It's so clear that while the term golfer's elbow might be catchy, understanding the condition as a chronic tendinosis, recognizing its broad occupational impact, and applying that phased interprofessional management approach are absolutely crucial for optimizing patient outcomes. It really challenges us to look beyond the label.
Absolutely. The emphasis on accurate diagnosis, early conservative intervention, and the vital role of patient education in preventing recurrence, it just cannot be overstated. It reminds us that often the simplest interventions, correctly applied and consistently maintained, yield the most profound and lasting results.
So what does this all mean for your practice? Well, next time you encounter a patient with medial elbow pain, maybe consider the broader context of their activities, perhaps the carpenter, not the golfer. Remember the degenerative nature and think about that evidence-based, phased approach we've discussed today. Think beyond the itis. If you found this deep dive valuable, please do take a moment to rate and share the show with your colleagues. It helps us reach more medical professionals like you. Thank you for joining us on the Deep Dive Ortho. We look forward to our next exploration into the fascinating world of orthopedics.